The digestive system consists of the GI tract and then also those accessory organs of digestion, include the liver, gallbladder, and then the exocrine pancreas. The basic job of the digestive system is to break down ingested food, prepare it for uptake by the body's cells, also provide water, and eliminate wastes. Food breakdown is going to begin in the mouth with mastication, where the food is broken down. In addition to getting enzymes that start, we have salivary amylase, salivary lipase, and then from there it gets passed down through the esophagus into the stomach and then processed in the duodenum, jejunum, and then ultimately out through the large intestine and anus. So in the stomach, the fluid and partially digested food pass into the small intestine, where bile and enzymes are secreted by the liver, enzymes from the exocrine pancreas, and we get small intestinal epithelium enzymes, which then break it down into absorbable components of proteins, carbohydrates, and fat. Those nutrients then pass through the small intestinal epithelium into the blood vessels, into the lymphatics, and carry them to the liver via the hepatic portal circulation. There, it's further processed and stored accordingly. So ingested substances and secretions that are not absorbed in the small intestine pass into that large intestine, where the fluid continues to be absorbed. We get much more solid waste. It passes into the rectum and it is eliminated through the body. Except for chewing, swallowing, and defecation of the solid waste, the activities of the digestive system are controlled by hormones and the autonomic nervous system. Those ingested substances move through the GI tract. They trigger the release of hormones that stimulate or inhibit muscular contractions, which is gastrointestinal motility, and that is going to mix and propel the food from the esophagus to the anus. Histologically, the structure and function of the gastrointestinal tract consists of 4 layers. From the inside out, they are the mucosa, submucosa, muscularis, and serosus or adventitia. They vary in thickness, and each layer has sublayers. There are intrinsic nerves that are located solely here. Neurons from the enteric nervous system are controlled by local and autonomic nervous system stimuli. The enteric nervous system comprises 3 nerve plexuses, and they are located in the different layers of the gastrointestinal wall. So you can see here we have, let's start with the outer layer, which is going to be the serosa, and that is the peritoneum, and the connective tissue layer, that is going to have the supply of the blood vessels and the mesentery. The next layer would be the muscularis. Now, the muscularis has 2 layers. We have a circular muscular layer, and you can see that that is running histologically this way. And then we have a longitudinal muscle layer. That is going to help us with our peristalsis. These 2, myenteric or submucosal plexus, also have other names that we refer to them as. The submucosal plexus is called the Meissner plexus, and the myenteric plexus is called the Auerbach plexus. And you can see they have different layers of nerve endings going through. So the enteric plexus neurons regulate the motility, reflexes, blood flow, absorption, secretions, and immune response. So very important and heavily involved. Then the next layer is the mucosal layer, and we have mucosal epithelium. This also has the lamina propria, and then we have a muscularis mucosa. So this is really heavily involved in creating that mucosal barrier. So high yield when we get into certain areas is that layer of protection that we have for the mucosis, the mucus production to coat the areas that need it. So the physiology of the GI system is ingestion of food, secretion of fluid and digestive enzymes, mixing and movement of food and waste through the body, getting digestion of food into smaller places. We ingest macromolecules, and we do have to break those down. Absorption of those nutrients, and then excretion of the waste. The mouth is the site of chewing and mixing of the food with the saliva. There are 32 permanent teeth in the adult mouth, and they are very important for speech and mastication. As the food particles become smaller and move around in the mouth, taste buds are continuously stimulated, adding to the satisfaction of eating. And then we also have the tongue surface and soft palate that contain taste receptors, and those are salty, sour, bitter, and savory, and sweet. They also stimulate the olfactory nerve, which helps initiate salivation and secretion of the gastric juice in the stomach. That is called the cephalic stage. And then we have the ability of the tongue to propel the food backwards so that we can swallow it and get it moved down the esophagus. We have two parts to process of digestion. So we have mechanical digestion and we have chemical digestion. That's what this slide is about. And this just tells us exactly what is happening on the mechanical side versus what is on the chemical side. So the mechanical side of getting the food broken down here is mastication. The carbohydrate and salivase, so we have salivary amylase, and that starts the breakdown of carbohydrates. There is also salivary lipase, but it's not very heavily involved in that. And this just gets the process started. Most of the breakdown happens in the duodenum. So then the esophagus is just a tube of transport, and it is just a mechanical from point A to point B. So there's no technical digestion that happens within the esophagus. Next site of digestion is in the stomach. So we have mechanical digestion, which is the peristaltic mixing and propulsion that happens with those longitudinal and circumferential muscles. And we'll go much more in depth into that later, but that is going to mix and propel and get the acid available to that, be able to break down that chyme. The chemical digestion of proteins happens in the stomach. And then we get absorption of lipid-soluble substances such as aspirin and alcohol actually get absorbed in the stomach. Next up is the small intestine. And then we have mechanical digestion, which is continued mixing and propulsion. And this is primarily a change to segmentation. Chemical digestion here happens a lot. So we have carbohydrate, lipid, protein, and nucleic acid absorption. And basically the digestive system really happens in the small intestine. Absorption of peptides, amino acid, glucose, fructose, lipids, water, minerals, and vitamins happen in the small intestine. Once we get into the large intestine, so mechanical digestion is segmental mixing, mass movement is by propulsion, and that is after we get more into the large intestine. Here we get no chemical digestion except for by bacteria. There is a lot of colonic bacteria. It is good bacteria. It does its job. We need it. Absorption of ions, water, minerals, vitamins, and small organic molecules that are produced by that bacteria. Propulsion then out of the system, and we get release of the end product, which is our stool. So let's look at salivation a little closer. So we have multiple salivary glands. However, we're going to focus on the three main pairs of salivary glands, and they are submandibular, sublingual, and the parotid. Each day we secrete about 1 liter of saliva, and it mostly consists of water, and then it has varying amounts of mucus, sodium, bicarb, chloride, potassium, and that salivary amylase. It has a pH of 7.4 to neutralize acids and prevent tooth decay. Also contains some IgA, which helps to prevent infections. Certain drugs will stimulate or shut down, and you can see here atropine, which is an anticholinergic, shuts down the cholinergic saliva glands. So this would be in that rest and digest, that autonomic nervous system, the parasympathetic branch would stimulate this to be happening because we're resting and digesting. So the sympathetic and parasympathetic divisions of the autonomic nervous system control salivation. Cholinergic parasympathetic fibers stimulate the salivary glands and inhibit salivation. That can also make the mouth dry. Beta adrenergic stimulation of the sympathetic fibers increases salivary secretion. The bicarb concentration of saliva sustains the pH, and that neutralizes those acids. So we'll move on to swallowing. The esophagus is that hollow muscular tube. It is approximately 25 centimeters long and conducts substances from the oropharynx to the stomach. And it is moved by peristalsis, the coordinated sequential contraction and relaxation of that outer longitudinal and inner layer of muscles. The pharynx and the upper third of the esophagus contains striated muscle that is directly innervated by the skeletal motor neurons that control swallowing. And swallowing is actually a very complex process, and that's why we have speech therapists to evaluate issues with that. So they're subspecialty. Peristalsis, the pharynx and the upper third of the esophagus contain that muscle. The middle third contain a mix of striated and smooth muscle, and then that lower third is smooth muscle only. and that is innervated by the preganglionic cholinergic fibers from the vagus nerve. The greater the tension, so as the food passes through, the greater the tension, the greater the intensity of esophageal contraction. Intense contractions can cause pain similar to heartburn or angina. So at the end of the esophagus, it is open and closed by a sphincter. We have the upper esophageal sphincter and the lower esophageal sphincter, which is the cardiac sphincter. This is what prevents regurgitation into the stomach, and the lower esophageal sphincter is located near the esophageal hiatus, and that is the opening of the esophagus into the stomach. So this is mediated by the trigeminal nucleus, the nucleus tractus solitarius, and the reticular formation of the brainstem. It also involves other brain regions, including the insula, claustrum, and cerebellum. There are two main phases. We have the first phase, which is the oropharyngeal, which is voluntary. That is while the food bolus is in the mouth. And then we have the esophageal, which is involuntary. Once that food bolus passes into the tongue, it is forced posteriorly toward that pharynx. And as the tongue pushes up against that hard palate, we have superior constrictor muscle of the pharynx contracts, and that is going to prevent that food from coming back into the nasopharynx. At that same time, we have respiration is inhibited and the epiglottis folds down, which prevents us from aspirating. This is a coordinated event and it's less than 1 to 2 seconds, so very quick. Then when we get into the esophageal involuntary phase, the bolus is transported via sequential contraction and relaxation of that outer longitudinal contraction, and that pushes the food bolus down. The esophageal phase takes about 5 to 10 seconds, and that bolus moves about 2 to 6 centimeters per second. So peristalsis immediately follows that oropharyngeal phase of swallowing. That is called primary peristalsis. And then when the food becomes stuck in the esophagus lumen, the distension of the esophageal wall stimulates a secondary peristalsis, and that is a wave of contraction and relaxation that is independent of that voluntary swallowing. Non-adrenergic, non-cholinergic vagal impulses relax the lower esophageal sphincter. Also, progesterone, secretin, and glucagon will relax the lower esophageal sphincter. Cholinergic vagal stimulation and gastrin, which is a GI hormone we're going to talk about in a little bit, they both stimulate the digestion. Next up is the stomach, which is that hollow muscular organ that stores the food. During eating, secretes digestive juices, mixes the food with those juices, and propels partially digested food. And this has a name which we call chyme into the duodenum of the small intestine. So there is the esophagus. We have the lower esophageal sphincter, which would be in here. And then we have areas of the stomach, and you can see that musculature in there. So here's what we call the fundus. So that's that top area here. Then we have the body. We have the cardia, which is more of this situation, so closer to the heart, helps you kind of remember that. We have the greater curvature, we have the lesser curvature, and then we have the pyloric sphincter. This is the antrum, which is the lower part. So the stomach has those 3 layers of smooth muscle. We have an outer longitudinal layer, a middle circular layer, and then an inner oblique layer. And the inner oblique layer is that most prominent, you can see here. So there is the longitudinal, here is that circular, and then here is that oblique layer. These layers become progressively thicker into the body and the antrum of the stomach. And this is where a lot of the food is mixed, churned, and then pushed into the duodenum. The blood supply to the stomach is from the celiac artery, and it's so abundant that nearly all arterial vessels must be occluded before there would be any ischemic changes of the stomach wall. So the sympathetic and parasympathetic divisions of the autonomic nervous system also innervate the stomach. Some of the autonomic nerves are intrinsic, meaning that they are going to originate in the CNS, and they are controlled by centers in the brain. The extrinsic sympathetic fibers reach the nerve stomach by the celiac plexus, whereas extrinsic parasympathetic fibers enter through the gastric branch of the vagus nerve. Here, the myenteric Auerbach and the submucosal Meissner plexus are intrinsic and part of that enteric nervous system. Very few substances are actually absorbed in the stomach, and it is impermeable to water. but it may absorb alcohol and aspirin and other non-steroidal anti-inflammatory drugs. Gastric motility, so this increases with the initiation of peristalsis waves that sweep the antrum, and it's mediated by a gastric pacemaker cell, and that initiates a depolarization which moves that upper part then in a wave format to the lower section. So we have a couple gastric hormones that are involved in this. Gastrin and motilin are the big ones, and the vagus nerve are stimulatory in this situation. So they are influenced both by neural and hormonal activity. The vagus nerve increases the rate of contraction by lowering the threshold potential for the muscle fibers. And then we get that neural and biochemical muscle contraction, and that follows that depolarization that we talked about with the other muscle groups. Sympathetic activity and secretin are inhibitory in this situation, and they make the threshold more negative, therefore decreasing peristalsis. So again, think about your rest and digest. This is going to be parasympathetic, and we don't want stimulation if we have fight or flight going on, which is going to be our sympathetic nervous system. So we get gastric mixing of the subsequent context, which would be the chyme, and this can take several hours, about 3 to 6, depending on the composition as well as volume of the fluid intake. So we get an oscillating motion that breaks down the large food particles. We have all those digestive juices in there, and that just basically, like a washing machine, back and forth, just mixes that chyme and breaks down into those macronutrients. So we have gastric emptying, and this is the movement of the gastric contents into the duodenum. And this depends on volume, osmotic pressure, and chemical composition of the chyme. So if we have larger volumes of food, it's going to increase that gastric pressure, peristalsis, and emptying. Solids, fats, and non-isotonic solutions actually delay gastric emptying. One of the main hormones here is cholecystokinin, and this is released in response to fat digestion. And this slows down gastric emptying so that the fats do not get into that duodenum at a rate that exceeds bile and enzymatic secretion. So cholecystokinin is a hormone that inhibits food intake. It reduces gastric motility and decreases gastric emptying. So when we're talking about that gastric secretion, they enter from the pancreas, liver, and duodenal mucosa. Their job is to neutralize gastric hydrochloric acid in the duodenum. They also are going to influence absorption of fats and carbohydrates and protein. Peristaltic activity in the stomach is influenced by blood glucose levels as well. Low blood glucose levels stimulate the vagus nerve and gastric smooth muscles, increasing the rate of contraction and gastric emptying. Hyperglycemia delays gastric emptying, so blood sugars have a direct influence. When we talk about the gastric secretions, so we have specialized cells located throughout the gastric mucosa, and they produce mucus acid, pepsinogen, enzymes, hormones, intrinsic factor, and gastroferrin. Intrinsic factor is necessary for intestinal absorption of B12. The hormones are then secreted into the blood and travel to target tissues in the bloodstream. The other gastric secretions are released directly into the stomach mucosa, and intracellular tight junctions, bicarbonate secretion, and submucosal acid sensors form a protective barrier against acid and proteolytic enzymes, which would otherwise destroy and damage this gastric lining. So in the fundus in the body of that stomach, the gastric glands of the mucosas are the primary secretory units. Several of these glands empty into a common duct known as the gastric pit. Within these cells, the parietal cells secrete hydrochloric acid, intrinsic factor, and gastroferrin. The chief cells secrete pepsinogen and gastric lipase. Pepsinogen is an enzyme precursor that is readily converted to pepsin, and that is converted in the presence of hydrochloric acid. Then we have G cells, and they secrete gastrin, and that will further secrete hydrochloric acid, pepsinogen, and histamine. When we talk about that gastric acid secretion and inhibition, there's a couple different phases. I alluded to that: the cephalic phase, the gastric phase, and the intestinal phase. There's also this one called basal or an interdigestive phase, And what this is kind of that background digestive phase. So the output varies from about 0 to 30% of maximal acid output. And this is controlled the background levels by acetylcholine and histamine. And that output is limited by simultaneous release of inhibitory factors. We go back and look at the cephalic phase. So this is really that first phase of gastric acid secretion. So what happens is the brain starts the process with the thought, smell, sight, or taste of food with the intent on eating it. So this then leads to vagal stimulation of the parietal cell and the antral G cells, which secrete that gastrin, as well as the pepsin, which is going to be, well, the pepsinogen, which is going to be converted to pepsin by that hydrochloric acid in addition to the hydrochloric acid. So all of that gets stimulated with the emotional sensory stimuli. Once the food actually gets into the stomach, then we move on to the gastric phase. So that's entry of the food into the stomach, initiates and then enhances the variety of gastric juices and mechanisms by which they are obtained. That intragastric buffering enhances secretion by maintaining a less acidic pH. We have chemical stimulation of those parietal cells, and we have distension, which elicits a vasovagal and intrinsic reflexes. Ways that we would inhibit the gastric phase would be acidification of the antrum, which is going to decrease the gastrin, the G cell release of the gastrin. There's also going to be mediated by acid release of somatostatin. And then as that stomach empties, the buffering capacity of the food decreases. So all of these, decreased G cell, release of somatostatin, and then emptying of the stomach would inhibit more gastric secretion from happening. The last phase is the intestinal phase, and this is where the food products in the small intestine, and it's usually released inhibiting factors, but protein digestion products can demonstrate a slight stimulatory effect. And this gives us less than 10% maximal acid output. How do we inhibit this phase? Presence of acid, fat, or hypertonic solutions in the duodenum inhibits gastric acid secretion. So this is just a really nice slide to kind of pull it all together when we're talking about that gastric secretion and the nerves involved. So you can see here we have the vagus nerve from the parasympathetic. So that's going to go over here and stimulate acetylcholine. And acetylcholine is going to stimulate the parietal cells, and the parietal cells are going to give us hydrochloric acid. They're also going to stimulate intrinsic factors so that we can get vitamin B12 absorption, which is going to happen over in the ileum. So in the back of the parietal cells, we have histamine receptors, H2, and that's where this comes in. So you can see the stimulatory effect on the H2 receptor that's on the back of the parietal cells. These are enterochromaffin-like cells, and you can see that gastrin goes out into the circulation, is stimulatory to the enterochromaffin-like cells, and then that is also going to go and stimulate histamine, and then histamine goes to the parietal cells, we get acid. So here gastrin is going to produce hydrochloric acid by the enterochromaffin-like cells. The other thing, we have the vagus nerve continuing down here. So then we have GRP is gastrin releasing protein, and that's on those G cells. So remember, G cells for gastrin. So you get direct stimulation of acetylcholine, which is back on the slides, as well as the gastrin releasing protein. So then you also get the mucus cells, which are, producing that mucus to help coat. Here are the chief cells. So you can see gastrin is also going to stimulate the chief cells, and that's where we get pepsinogen. And then pepsinogen comes in here. Once it gets in contact with the hydrochloric acid, then we get pepsin. And pepsin is a very potent protein breaking down enzyme. Here are those D cells. The D cells are going to get us somatostatin. So as the chyme gets moved down in here, we get that buffering that we need to. We have to start getting less acidic, because once we get out the pyloric sphincter, then we need to be more basic when we get over here to the duodenum. So we get somatostatin, which is going to decrease the hydrochloric acid and decrease our stimulation. So you can see once we get over here into the duodenum, then we have some other cells that are involved. Here you can see the secretin, GIP is gastrin inhibitory peptide, and it's just going to do exactly what it says. So it's going to inhibit. And then we also have eye cells, which release that cholecystokinin. So there are all those enzymes that we were talking about. The hormones of the GI tract. So we have gastrin, histamine, somatostatin, acetylcholine, and gastrin-releasing peptide. The small intestine, we have motilin, secretin, cholecystokinin, enteroglucagon, GIP, which is that gastrin inhibitory peptide, and pancreatic peptide. So that is just the breakdown of everything that you saw over here. Moving on to the small intestine. The small intestine is coiled within that peritoneal cavity, and it's about 5 to 6 meters long. It is divided into 3 segments. We have the duodenum, the jejunum, and the ileum. The duodenum begins at the pylorus and ends when it joins the jejunum. And then the jejunum is at a suspensory ligament called the tract ligament. And then the end of the jejunum and beginning of the ileum are not distinguishable by a biomarker. However, the jejunum has a slightly larger lumen than the ileum. We have an ileocecal valve, which is a sphincter, and that controls the flow of digested material from the ileum into the cecum. So the duodenum lies behind the peritoneum, or retroperitoneal, and that it has an essential role in mixing food with those digestive juices from the liver and the pancreas. Good blood supply here as well. That from the duodenum arises primarily from that gastroduodenal artery, which is a small branch off of that celiac artery. And then the jejunum and ileum are supplied by the superior mesenteric artery branches, and blood flow to these areas significantly increases when we get digestion. So we still have those enteric nerves from both divisions of the autonomic nervous system, so parasympathetic and sympathetic. Secretion, motility, and intestinal reflexes, such as relaxation of the LES, are mediated parasympathetically by that vagus nerve. And then we have the myenteric plexus, and the submucosal plexus of that enteric still functions down here in the duodenum and small intestine. So when we're talking about intestinal absorption here in the duodenum, we're talking about absorption through the villi. So here's a nice little breakdown of it. These are what are these folds. And then in the folds, we have these brush borders, and we have these microvilli that are actually on top of the brush borders. So these columnar cells closely adhere to each other at the sites. So those tight junctions. Water and electrolytes are absorbed through the intracellular spaces, and then each columnar epithelial cell contains tiny projections called microvilli. Microvilli create more surface area, and that is that brush border. Between the bases of the brush border of the microvilli, we have these things called crypts of Lieberkühn, and those are intestinal glands which extend down into the submucosal layer. So here, these undifferentiated cells arise from stem cells at the base of the crypt, and then they move upward towards the tip of the villus, and there they're going to mature and become those columnar epithelio-secretory cells, which we get our water, electrolytes, and enzymes from, or goblet cells, which is what we are going to give for the mucus cells. The entire population is replaced every 4 to 7 days. Factors can influence this process of cellular proliferation, and that includes starvation, vitamin B12 deficiency, cytotoxic drugs, irradiation, and they shorten the lifespan of these villi. And then that can result in malabsorption and diarrhea. So the processes of intestinal digestion is initiated in the stomach by gastric hydrochloric acid and pepsin. Those are the main things. They will break down the food into fibers, proteins. The chyme passes into the duodenum in a liquid that contains small particles of undigested food. Digestion then continues in the proximal portion of the small intestine by the action of the pancreatic enzymes, the intestinal brush butter or enzymes, and bile salts. Carbohydrates are broken down into monosaccharides and disaccharides in the proximal small intestine. Proteins are degraded further into amino acids and peptides. Fats are emulsified, and they go into fatty acids and monoglycerides. So these nutrients, then along with water, vitamins, electrolytes, they're absorbed across that intestinal mucosa and then into the blood for active transport. So here's a nice little kind of schematic of that intestinal absorption and what gets absorbed where. So I thought this was really nice. And then you can also see here where the pancreatic enzymes come in. There's your bile, and then you can see what is being absorbed. Next up is the large intestine. So this is approximately 1.5 meters long and consists of the cecum, appendix, colon, rectum, and anal canal. The cecum is that pouch that receives the chyme from the ileum, and then that attached to the cecum is the variform appendix. This appendage is having little or no physiologic function. From there, the cecum, the chyme enters the colon, and it's a 4-part length of the intestine that loops upward, transverses the abdominal cavity, and then descends to the anal canal. The 4 parts of the colon are the ascending colon, the transverse colon, the descending colon, and the sigmoid colon. There are 2 sphincters that control the flow of the intestinal contents through the cecum and the colon. It is the ileocecal valve, and that's going to admit the chyme from the ileum to the cecum. And then we have the Oberon sphincter, which is the rectosigmoid sphincter, and that controls the movement of waste from the sigmoid into the rectum. In the cecum and the colon, there's a longitudinal muscle layer that consists of 3 longitudinal bands called tennae coli. They are shorter than the colon, giving the colon that gathered appearance. And then we have circular musculars of the colon that separate the gathers into outpotchings, and those are called the haustra. The primary type of movement in the colon is segmental, and that is when the circular muscles contract and relax at different sites, and that shuttles the intestinal contents back and forth between those contracting and relaxing haustra. The movements massage the intestinal contents, which is now a fecal mass, and at that point facilitate the absorption of water. And then it's a propulsive movement in the proximal to distal contraction of the several haustral units at one time. And then peristaltic movements also occur and promote emptying of the colon. So there is a lot of bacterial fermentation, which converts the chyme into feces and releases the vitamins. That includes vitamin K, the B vitamins, and biotin. When we talk about the intestinal bacteria or the gut microbiota, we are sterile at birth, and then it becomes colonized with E. coli, Clostridium, Streptococcus within a few hours. Within a couple weeks, we have a gut biome well established. The actual role is metabolism of bile salts, estrogen, androgens, nitrogenous bases, various drugs, lipids, and then also conversion of unabsorbable carbohydrates to absorbable organic acids, synthesis of those K and B vitamins. And you can see the degree of bacteria. So when we're in the colon, we have a lot more bacteria per milliliter of fluid versus the small intestine. And you can see we have ileum to cecum, we have Clostridia, anaerobic lactobacilli, and coliforms. In the duodenum, we have primarily streptococci, lactobacilli, staphylococca, enterobacteria, and bacteriodes. But you see the difference in the amount of bacteria. There's also antimicrobial peptides and IgA as a component in the small intestine, and that's those Peyer's patches and Paneth cells, and they provide defenses against those pathognomic microorganisms. Genetics, diet, environmental pollution, personal hygiene, vaccination, infection, antibiotics, other drugs, radiation exposure, all will alter that normal intestinal microbiota. This is the important role of the bacteria, and that's why we do push probiotics to restore that microbiota, especially when patients are on antibiotics, as that will destroy it. Okay, now we're going to move on to the structure function of the accessory organs of digestion. So the liver, gallbladder, exocrine, pancreas all secrete substances that are necessary for the digestion of the chyme. Those secretions are delivered to the duodenum through the sphincter of Oddi at the major duodenal papilla. The liver produces bile, which contains salts necessary for fat emulsification and absorption. And then between the meals, that bile is stored in the gallbladder. The exocrine pancreas produces enzymes needed for complete digestion of carbohydrates, proteins, and fats. First up, we're going to talk about the liver. So the liver is the largest solid organ in the body. It's located right under that right diaphragm and divided into right and left lobes. The larger right lobe is divided further into the caudate and quadrate lobes. The falciform ligament separates the right and left lobes and attached to the liver in the anterior abdominal wall. The liver is covered by a fibroelastic capsule called the glycan capsule, and that contains the blood vessels, the lymphatics, and the nerves. If the liver is diseased or swollen, distension of that capsule is what causes the pain because it's innervated by those sensory neurons of the lower intercostal nerves. So the metabolic functions of the liver are wide and vast, and it requires a large amount of blood, and that receives the blood from both arterial and venous sources. So we have the hepatic artery, which is formed by the confluence of the superior mesenteric and splenic veins, and that receives the blood from the inferior mesenteric, gastric, and cystic veins. The hepatic portal vein, which receives the deoxygenated blood from the inferior and superior mesenteric veins and the splenic vein, that delivers about 1,000 to 1,200 milliliters a minute of blood to the liver. The hepatic artery is formed by the confluence of the superior mesenteric and splenic veins and receives blood from the inferior mesenteric, gastric, cystic. This provides oxygenated blood from the liver at a rate of 400 to 500 milliliters a minute. And that is approximately 25% of the cardiac output. So the various functions of the liver are vast. Production of bile, which carries away waste, break down fats in the small intestine, productions of certain blood plasma, proteins, cholesterol, conversion of excess glucose into glycogen, regulation of amino acids, the process of hemoglobin and its iron content, so liver stores iron, conversion of poisonous ammonia to urea, clearing of drugs and poisonous substances, regulating blood clotting, resisting immune factors, resisting infections, promoting immune factors, removing bacteria, clearance of bile, and then if the liver is damaged, harmful substances, byproducts, those are normally excreted into the bile or blood. Those bile byproducts enter the intestine and then leave the body in the form of feces. When the liver is dysfunctional, then all of this can build up in the system. So we have those two main lobes. They're made up of 8 segments, and each consists of about 1,000 lobules. So we have small lobes within the larger lobes, and they are connected through these small ducts and tubes to connect to the common bile duct. The common hepatic duct transports the bile made by the liver cells to the gallbladder and duodenum via the common bile duct. A couple different cell types that are in here. So we have hepatocytes, which are the functional cells of the liver. They are capable of regeneration. They secrete electrolytes, lipids, lecithin, bile acids, and cholesterol into a caniculi. So here is a breakdown of a hepatocyte. So here is a branch of that hepatic vein. Here is the hepatic portal vein. Here we have the hepatic artery and the branch of the bile duct. So if you follow the arrows through, then you can see exactly which way the items are moving in that. So here's what the hepatocyte looks like. And then we're just looking, this is that breakdown even further. So you can see it's almost got like a star-like shape. And then at each corner, we have a branch of the bile duct, hepatic portal vein, and hepatic artery that is feeding that. Lipocytes are star-shaped cells that store lipids and vitamin A. Kupffer cells are phagocytic cells, so that's a part of that mononuclear phagocyte system. Remember, I told you that macrophages have different names in different areas of the body, so that would be a Kupffer cell. Stellate cells, these are multifactorial and they contain vitamin A as well. Regulates the most chemical levels in the blood, excretes a product called bile, and that helps carry waste products away from the liver. All blood leaving the stomach and intestines passes through the liver, processes this blood, breaks down, balances, and creates nutrients, and metabolizes drugs into forms that are easier and non-toxic. So we have a central vein that is located in the center of the lobule with plates of hepatocytes disposed radially. The branches of the portal vein and hepatic artery are located on the periphery, and blood from both vessels perfuses the sinusoids. Peripherally located bile ducts drain the bile caniculi that run between the hepatocytes. So metabolism of nutrients by the liver, so fats are ingested, that they're absorbed, they enter the liver, and then primarily as triglycerides. They are hydrolyzed to free fatty acids or glycerol to produce ATP or released into circulation bound to proteins, those are those lipoproteins. They're carried to adipose tissue for storage. There's also synthesis of phospholipids and cholesterol for bile salts, steroids, and other molecules. Proteins, so within the hepatocytes, protein is deaminated and converted to carbohydrates by removal of the ammonia. Ammonia is converted to urea by the liver, passes into the blood, and is excreted by the kidneys. Plasma proteins, such as immunoglobulins, are formed in the lymph nodes and synthesized by the liver. Carbohydrates, it controls blood glucose stability by releasing glucose in times of hypoglycemia and fasting, and takes up glucose in times of hyperglycemia. Bile secretion, so bile is that alkaline, bitter tasting greenish yellow fluid. It contains bile salts. Those bile salts are conjugated bile acids, cholesterol, bilirubin, electrolytes, and water. They are required for emulsification and absorption of fats. Most bile salts are actively reabsorbed and re-enter hepatic circulation, called the enterohepatic circulation. The liver assists intestinal digestion by secreting about 700 to 1200 milliliters of bile a day. Primary bile salts are cholic acid and chenodeoxycholic acid. These acids are synthesized from cholesterol by the hepatocytes. The secondary bile acids are deoxycholic acid and lithocholic acid. These are formed in the small intestine by the action of the intestinal bacteria, after which they are absorbed and then flow to the liver. Both forms of the bile acids are conjugated with amino acids glycine and taurine to the liver to form the bile salts. Conjugation makes the bile acids more water soluble, thus restricting their diffusion from the duodenum in the ileum. The primary and secondary bile acids together form the bile acid pool. Choleresis is bile secretion, and a choleretic agent stimulates that release. Choleretics include secretin. Another strong stimulant of choleresis is an increased amount of bile. Other things would also promote secretion of that would be bicarbonate from the caniculi and other intrahepatic bile ducts, cholecystokinin, and vagal stimulation. Here's a nice schematic for bile secretion. So you can see the bile salts consist of 95% old recycled bile salts, 5% newly synthesized bile salts. So then it goes into the common bile duct, into the circulation of the small intestine, dropped in there at the sphincter of Oddi and the duodenum, and then it gets processed. They are reabsorbed by the small intestine, and only about 5% of them are lost in the feces. So this blue line is that enterohepatic circulation of the bile salts. Goes into the hepatic portal vein, back up into the liver, reabsorbed and recycled for that enterohepatic circulation. Metabolism of bilirubin. So bilirubin is that byproduct of the destruction of the aged red blood cells, and it gives bile that greenish black color and then produces a yellow tinge that we get for jaundice. Aged red blood cells are taken up and destroyed by macrophages of the mononuclear phagocyte system, primarily in the spleen and the liver. And then those macrophages, which we call Kupffer cells. And then within these cells, the hemoglobin is separated into those compartments. Remember, heme and globin. The globin component is further degraded into its constituents, amino acids, which are recycled to form new proteins. The heme is converted to biliverdin by enzymatic cleavage of the iron. The iron attaches to the transferrin in the plasma and then can be stored in the liver or used by the bone marrow to make new red blood cells. The biliverdin is enzymatically converted to bilirubin in the macrophage and then released into plasma. In the plasma, the bilirubin binds to albumin, and then it is considered unconjugated bilirubin or free bilirubin, which is lipid soluble. Unconjugated bilirubin also has a role as an antioxidant and provides cytoprotection. In the liver, unconjugated bilirubin moves from the plasma in the sinusoids into the hepatocyte. Within the hepatocyte, it joins with glucuronic acid to form conjugated bilirubin, which is now water soluble. Conjugation transforms bilirubin from lipid soluble that can cross biologic membranes to a water soluble that can be excreted in the bile. When the conjugated bilirubin reaches the distal ileum and the colon, it is deconjugated by bacteria and converted to urobilinogen. Urobilinogen is then reabsorbed in the intestines and transported to the kidney. This is what gives urine its yellow color, and there's a small amount of urobilin that is recirculated back into the liver and eliminated in the feces as stercobilin, and that's what gives the stool its brown color. The liver alters exogenous and endogenous chemicals such as drugs or poisons, foreign molecules, hormones, and makes them less toxic. This is called metabolic detoxification or biotransformation. It diminishes intestinal or renal tubular reabsorption of those potentially toxic substances and then facilitates their intestinal and renal excretion. This is the way alcohol, barbiturates, amphetamines, all kinds of drugs and hormones are metabolized or detoxified. Although it's usually protective, sometimes the end products of metabolic detoxification become toxic. Those of alcohol metabolism, for example, are acetaldehyde and hydrogen, which will actually damage the hepatocytes. Acetaldehyde damages the cellular mitochondria, and excess hydrogen promotes fat accumulation, and that is what impairs the liver to function. The liver vasculature and hematologic function, so it's an extensively vascular and a large network. It stores large volumes of blood, and then that can be released into the vascular system in times of hemorrhage. We have those Kupffer cells, which are those macrophages, which remove bacteria and foreign particles, and then it's synthesis of many clotting factors, vitamin K, 1, 2. Moving on to the gallbladder, so this is primary function is to store and concentrate bile between meals. And then what happens is within 30 minutes of eating, the gallbladder contracts, forcing the bile through the cystic duct. Common bile duct, sphincter of Oddi relaxes, the bile flows from the duodenum to the major duodenal papillae. We get hormonal regulation primarily by cholecystokinin in the duodenal jejunal mucosal and the presence of fat. So that gallbladder is a sac-like organ that lies inferior to the internal surface of the liver. The pancreas is approximately 20 centimeters long, and its head is tucked into the curve of the duodenum and its tail touching the spleen. The pancreas lies deep in the abdomen behind that stomach, and it's very unique because it has both endocrine as well as exocrine function. The endocrine pancreas secretes insulin, glucagon, somatostatin, and a pancreatic polypeptide. The exocrine is now these acinar cells, and they are composed and secrete enzymes and networks of ducts that secrete alkaline fluids with important digestive functions. Secretions drain into a system of ducts that lead into the pancreatic duct, which empties into the common bile duct at the ampulla of Vater, and then through the duodenal papilla into the duodenum. Pancreatic innervation comes from the parasympathetic neurons of the vagus nerve, and that stimulates the enzymatic and hormonal secretion. The fluids are an aqueous secretion, include potassium chloride, calcium, sodium, mag, bicarb, and that neutralizes that acidic chyme. The pancreatic enzymes, these are ones that are going to hydrolyze proteins, which are called proteases, carbohydrate, which are called amylases, and fat, which are called lipases. Proteolytic, which means protein digesting enzymes, include trypsin, chymotrypsin, carboxypeptidase, and elastase. And they are all secreted in inactive forms to prevent autodigestion. So you add ocinogen to each one of these to get those precursor forms. And that basically is what protects the pancreas from digesting itself. Once they're in the duodenum, in the inactive forms, which are basically proenzymes, they're activated by enterokinase. And that is an enzyme that is secreted by the duodenal mucosa. Trypsinogen is the first proenzyme to be activated, and then that's converted into trypsin, and that stimulates the conversion of chymotrypsinogen to chymotrypsin and procarboxypeptidase to carboxypeptidase. And they basically, each enzyme cleaves specific peptide bonds in to reduce those polypeptides into smaller peptides. So pancreatic amylase is secreted in active form and digests intestinal carbohydrates by cleaving the alpha-1 4 glucosidic bonds to yield glucose and maltose. Pancreatic lipases hydrolyze triglycerides, cholesterol, and phospholipids down to free fatty acids in the intestine. There's a feedback mechanism that inhibits the secretion of more pancreatic enzymes. Testing of the gastrointestinal tract is going to be looking at digestive function. So there's diagnostic information that can be obtained from the medical history as well as those presenting signs and symptoms. So you can get plain radiographs. We can do barium contrast, also endoscopy, ultrasound, computer tomography, or MRI. Stool studies, which would be looking for resident microorganisms, and then detection of other things abnormal, such as Shigella, Salmonella, Vibrio cholera, is there occult blood, ova, and parasites. Other things, you could do a gastric acid stimulation, looking for duodenal ulcers, Zollinger-Ellison. You can do manometry, which is looking at swallowing, motility, and sphincter function. And then breath tests such as glucose or urea or lactose would be looking at intestinal overgrowth or presence of H. pylori. So we look at liver function tests. We're looking at serum enzymes. So we have ALK-Phos, which increases with biliary obstruction or cholestatic hepatitis. We have gamma glutamyl transpeptidase, and that also increases with that biliary obstruction and cholestatic hepatitis. Aspartate aminotransferase was previously known as serum glutamate oxalate transamase, SGOT, and that increases with hepatocellular injury and injury to other tissues, heart and muscle, in addition to ALT is alanine aminotransferase, and that was previously serum glutamate pyruvate transaminase. That also increases with hepatocellular injury and necrosis. It is liver specific. Lactate dehydrogenase. This is an isoenzyme that is elevated in hypoxic and primary liver injury. Then we have bilirubin, so unconjugated or conjugated, looking at direct or indirect, and then that process, whether it's involved with hemolysis, which is lysis of those red blood cells, or hepatocellular injury or obstruction. When we look at serum proteins, we're looking at the albumin and globulin, and they would be reduced. Albumin would reduce if there is liver injury, and then globulin would be increased if there's hepatitis. Other things, we would be looking at transferrin, because that would mean liver damage would decrease values, iron deficiency with increased values. Alpha fetoprotein, this is elevated in primary hepatocellular carcinoma. And then you have your acute phase reactants. Imaging could be ultrasound, CT, MRI. When we talk about pancreatic functions, so then we're looking at amylase, lipase, and urine versus serum, and basically going to indicate pancreatic inflammation. You can do a secretin test, which would be a decreased volume with pancreatic disease, as secretin stimulates pancreatic secretion. Also, you would be looking at stool fat and fecal elastase. You could also do some liver function tests. Common complaints, review these. So you have dysphagia, which would be either mechanical or functional. Another one would be anorexia, which is lack of appetite, and defined as weight loss. Differential is extremely broad, as you can see there. Nausea and vomiting, we have two different mechanisms, neurologic versus peripheral. And then review this here so that you know which ones and how we classify neurologic versus peripheral. I did include a vomiting differential diagnosis, whether it's vestibular, cerebral, or gastrointestinal. Constipation, we have a couple different types of this as well. You can see difficult or infrequent defecation, low residue diet, anticholinergic, opioids. Diarrhea, so this is stool with increased water consistency, still has a lot of deaths associated with it, and this is usually related to a food-borne diarrhea illness. You can see here invasive and inflammatory versus non-invasive, non-inflammatory. Abdominal pain, this is broad as well, acute versus chronic, generalized versus localized, sharp, dull, or colicky, and visceral, referred, or parietal. And we, depending on the location of it and the signs and symptoms associated with it, we can determine what's going on related on location. GI bleed, this is upper or lower, hematoemesis, hematochezia, melena, and then we have multiple different pathologies for upper or lower. Mortality rate can be significant related on certain types. Lower GI bleed, you can see the differential here and also the causes. That's it. Here are the references.